Can we all come and sit down, please? Can you come and sit down? Started, and I'd like to thank you all for coming. This is our Orange Roadshow. We're from St George Hospital in Sydney, and we've come today to talk about our research and how it relates to pregnancy, and also about the microbiome. So without any further ado, I'd like to ask Phil Donato to come up, the local state member for Orange, to come up and do the acknowledgement of country.
Thank you, Greg. And I'll begin today by acknowledging the Wiradjuri people, traditional custodians of the land on which we meet today, and pay my respects to their elders past, present and emerging, and I extend that respect to Aboriginal and Torres Strait Islanders people here today. Thank you. Enjoy.
And Liz Shaw from the hospital. Liz, come and say a few words.
Hello everybody, my name's Liz Shaw. I'm representing our General Manager of the hospital tonight, Catherine Allen, who couldn't be here. So I'm just going to extend a lovely welcome to you all. So in conjunction with the University of New South Wales Microbiome Research Centre and the St George Hospital, and sponsored fantastically by the Michael Tynan Challenge, we have a panel of expert doctors here tonight. So from the Michael Tynan Challenge Foundation, we are very lucky to have Madeline here and her daughter Prudence, and they're going to present tonight on Heartbreak after Preeclampsia and Mothers and Babies Microbiome Study. So we've got some amazing guest speakers here tonight. So we've got Associate Professor Greg Davies, we've got Professor Amanda Henry, Prof Imad El Omar, and also there's a number of other people from St George here tonight. We have Naomi Stroud and Lynn Roberts, and I've seen a few other tags of those people. So welcome to Orange. I hope you appreciate our lovely weather and you have a nice chilly morning. And welcome especially to everybody who's online tonight. We can see an amazing number of people who are there, so I hope you enjoy the night. Thank you.
Yeah, thank you, Phil and Liz. We've done that. So the format of the evening is that we're going to give 3 short talks, and at the end of the evening, then the 3 of us will sit up here, happy to answer any questions from the people from home. We're live streaming to the universe, and if you could please have your phone on silent, that'd be great. So these are the learning outcomes for the evening. Identify the risk of cardiovascular disease and diabetes after hypertension and pregnancy. Describe effective strategies to educate women about their increased risk. Describe the contribution of the microbiome to medical disorders in pregnancy. And to explain the potential of the MothersBabies study to improve our understanding of the microbiome during normal and abnormal pregnancy. So I'm just going to start first talking a little bit about hypertensive disorders of pregnancy and some of the long-term risks, which is during the pregnancy stuff, I've got some of the things that I couldn't leave out because they're sort of personal little, I guess, foibles of mine and related a lot to the research, the clinical research we've done in the past. So I'm going to talk about briefly some definitions so that everybody knows what we're talking about, talk about some things in pregnancy, briefly mention recurrence after first pregnancy, talk about the long-term risks, and then the P4 study, which I'll explain shortly. So for the addition, these are the definitions from the International Society of Study of Hypertension and Pregnancy guidelines, which I'd highly recommend to anybody who's interested in looking up references about this, because I know some of the people on that committee and they are very, very smart people, and it's very well referenced as well. So prior to pregnancy or before 20 weeks gestation with a blood pressure over 140/90, chronic hypertension, which covers all of these things, may be essential or secondary, white coat hypertension, which is greater than 140/90 in the clinic, less than 135/85 at home, and we are doing a lot of home blood pressure monitoring now, or a 24-hour ambulatory monitor. And this weird thing that only renal physicians know anything about called masked hypertension, that I never really quite understand, I have to say, but it's in the definition. So where it's normal blood pressure in the clinic, but it's raised at home or on ambulatory monitoring. Hypertension after 20 weeks, if it's just blood pressure, it's gestational hypertension. Transient hypertension, if it resolves after repeated testing. But studies actually show that about 20 to 30% of these women are going to go on to have either gestational hypertension or preeclampsia. Preeclampsia, which I'll talk about briefly, or preeclampsia superimposed on chronic hypertension. So the definition of preeclampsia is really gestational hypertension, which is after 20 weeks, with another symptom or another organ involvement. Most commonly, as we know, proteinuria, but other end organ impairment, neurological. We've given up, or in this definition, they've given up using hyperreflexia as part of it, because every pregnant woman you've ever tested the reflexes on is hyperreflexic. So if you get a general physician coming to see your patients, they'll tell you they're hyperreflexic, and you just have to learn to ignore it. Renal, apart from the proteinuria, they can get acute kidney injury as well, hematological, liver, pulmonary edema, rarely. And most of the time, most of the cases that pulmonary edema that I've seen is really been because we have caused it. So usually it'll be in women that we're inducing for preeclampsia. They've been on Synto, they've been given fluids for their epidural, they might be diabetic, so that you've overloaded them with fluids, and surprisingly their heart doesn't like it much. So most of the cases that I've seen, although a lot of the American reports, they seem to see a whole lot more of it, but that's probably just, they're not nearly as good at doctors as we are. I can say that in an Australian setting. And obviously it can affect the baby as well. So this is an excellent quote, I think, from the guidelines. Worldwide each year, preeclampsia is responsible for over 500,000 fetal and neonatal deaths and over 70,000 maternal deaths. So hypertensive disorders of pregnancy is about 10 to 12% of pregnancies, and preeclampsia about a third of those. And this is one of my own other little personal bugbears, is normal blood pressure actually varies quite a lot in pregnancy. And we all remember this sort of slide or something like it from our training. But so if someone presents to you at 12 weeks of pregnancy and her blood pressure is 120/80, she is actually hypertensive, because it's the average, the mean blood pressure at that gestation is actually much higher. The other thing is that if she presents to you at 12 weeks and her blood pressure is 110/70, her blood pressure may well have been higher if we go back here pre-pregnancy. So the message from that is if they're presenting later in pregnancy, in the second trimester, it may not be representative. And I can't attribute this slide apart from it came off the internet. Low dose aspirin, the triple test, which combines maternal history, mean arterial pressure, uterine artery pulsatility index, and maternal proteins, placental proteins, PAPA and PLGF. It will pick up 80% of women who will develop early onset, so that's prior to 34 weeks of pregnancy. The risk cutoff they quote is 1%, but early onset preeclampsia only makes up about 0.4% of pregnancies, but obviously they want to try and get as many as they possibly can at a reasonable cutoff. So low dose aspirin, which is now recommended to be 150 milligrams at night, will more than halve the number who develop early onset preeclampsia from 11 to 14 weeks through to 36 weeks. The other important thing to realise, there is no reduction in term preeclampsia. So we had a public meeting earlier on this afternoon, and we're talking to a lady who had preeclampsia in her second and third pregnancies. She was on aspirin for her third pregnancy and developed severe preeclampsia at 37 weeks. So it doesn't affect that. The other things that you may not be as aware of, calcium reduces the risk by 1/3 in low intake populations. So the studies were done, a lot of them in South America, but I don't know what your demographic is here, but our demographic in South Sydney is about 2/3 of our population is Asian, and a lot of these women will be lactose intolerant, so have a very low intake of calcium. So it is very simple to give them Caltrate. There are also very good RCTs, and the figures, the actual studies that they're based on are in the guidelines. I haven't put them in there because it's already a big slide. But it reduces the risk of gestational hypertension, preeclampsia, and GDM so significantly. And what they mean by exercise is, as you can see, brisk walking, cycling, and gardening, washing windows. I'm not sure you should be getting your pregnant wife out there washing windows, but you know. But the important thing is that during the activities, they can talk, but not sing, and they notice, and not sure who'd be singing washing windows either, but notices that their heart rate has increased. One of my other little private pet bête noires is choosing your machine. These machines automated machines were designed for monitoring blood pressures in an intensive care situation. They are not as accurate for diagnosing hypertension. This is a liquid crystal hybrid sphygmomanometer, which is exactly the same as a manual mercury sphygmomanometer. And it's interesting little backstory to this. We did a study on it a number of years ago, comparing it with Lynn Roberts here, our research midwife, did many studies comparing mercury, the liquid crystal, and an automated device, and the liquid crystal was much better. But prior to doing the study, we went to talk to the people, the A&D medical people, to try and get some funding to do the study, and met up with these rather dour-looking Japanese engineers, and they were not interested at all because they were engineers, and they said, well, you know, this is a waste of time, because of course it just measures exactly the same as this mercury sphygmomanometer, and that's exactly what it did. Measured exactly the same as a mercury sphygmomanometer. So obviously doesn't have mercury, so none of the occupational health and safety issues associated with mercury, but is much more accurate and is pretty cheap. So all our sphygmomanometers in the maternity part of our hospital are all like this, and that's the second question that you ask, you know, when you ask someone's blood pressure. If they say a person tells you their blood pressure is raised, was it measured on the manual machine? Next question, is it the right size cuff? Dipstick urine testing should be done with an automated urinalysis machine. The study we did a long time ago showed that the true positives increased from 48% with visual analysis to 74%, and this is a picture of the urinalysis machine, which costs $120 or something like that. If it's 1+ or more proteinuria, it needs quantitation. If the PCR is more than 30, it's abnormal, and this was actually done at St George Hospital, the work on which this was based. Once it's abnormal, you do not need to repeat it, because it's just a waste of everyone's time. The only exception is if the woman is developing progressively more severe preeclampsia, severe proteinuria, because if she becomes nephrotic, then she will lose all her fibrinolysin, so we would then put them on Clexane for 6 weeks postpartum till her clotting returns to normal. We have a system at our hospital which was set up by the renal physicians, so the obstetricians take no responsibility for the initiation of this exceptionally good idea. So any woman that has hypertensive and doesn't have proteinuria, we run this clinic Monday, Wednesday, Fridays. They come in at 9 o'clock in the morning, they have their bloods, and I just will get back to the SFLT1 PLGF ratio in a second. If they have proteinuria, send off a PCR. They have a CTG, they do the blood pressure 4 times, and the average is then their blood pressure for the morning, and then they get reviewed by an obstetrician and a renal physician at lunchtime. And I do that in my private practice as well. I find this is a very good way of assessing women. I don't know how long it takes you to get bloods back. You will usually get these back within a couple of hours, so it makes it very possible to assess the woman fully. The SFLT1 PLGF ratio is confusing to most people. The way I simplistically look at it is that PLGF is a really good thing to have in a pregnant woman's bloodstream because it dilates and builds blood vessels. All the growth factors bind to tyrosine kinase receptors, and SFLT1 stands for soluble FIMS-like tyrosine kinase. That's why they call it SFLT1, because it's impossible to remember. And so what happens in preeclamptic pregnancies is that high levels of the SFLT1, as they've demonstrated graphically there, inactivate a lot of the PLGF, and that increases your risk of preeclampsia. And this is a study that most people quote from the New England Journal, the prognosis study. Important to realise that it was done in women with suspected preeclampsia. So it wasn't done in all pregnant women, random pregnant woman, suspected preeclampsia before 37 weeks. So if the ratio was less than 38 or equal to 38, you had an almost 100% negative predictive value. So they weren't going to get preeclampsia in a week. However, if it was greater than 38, only 37% of them would develop preeclampsia in the next 4 weeks. So it wasn't really good at predicting who would get it, but it was good at ruling it out for the next week. We did a study comparing using the SFLT1 PLGF ratio in our practice with the day assessment unit versus clinicians, and it probably was a little bit better than us, but it really didn't matter because we were going to follow them up anyway, so we decided it's an expensive test. You would delay actually reviewing them because it would usually take more than a day to get a result in our system. So we haven't used it, but I wonder in a rural setting whether it would be a good test to use to ensure that if you were trying to toss up whether you were going to transfer someone in or to another centre. Talked about recurrence after hypertensive disorders in pregnancy. This is another study that Lynn did a number of years ago, which she really, really loved. Was looking at 1,500 women who'd had either preeclampsia or gestational hypertension in their first pregnancy, and then looked at 759 next pregnancies. So on the left-hand side here, we had those that had preeclampsia in their first pregnancy. The right-hand side, those that had gestational hypertension in the pregnancy. And then the bars are what happened in the second pregnancy. So if they had preeclampsia in the first pregnancy, they had a 14% chance of having preeclampsia in the second, a 13% chance of gestational hypertension. If they had GH in the first pregnancy, they had 6% chance of preeclampsia, 26% chance of GH in the second pregnancy. those figures I find completely impossible to keep in my head. So my take on that, there is about a 30% chance of recurrence in a subsequent pregnancy, and a lot of different studies have come up with those sort of similar figures. I haven't presented the data, but if you have severe disease in the first pregnancy, so early onset preeclampsia, HELLP syndrome, an elevated booking in blood pressure in the second pregnancy, i.e. essential hypertension, or other underlying risk factors like raised BMI or twins, then there's a higher risk. But the really important thing I think you need to stress to these women, because a lot of them are completely freaked out by what happened to them in their first pregnancy, is that they have a 70% chance of having a completely normal pregnancy. And this is, for me, is the money slide and my main motivation for coming out here. So if a woman has had hypertensive disease in pregnancy, she has a relative risk of 3.7 times of having chronic hypertension. She has 2.5 times the chance of ischemic heart disease, 2 times the risk of stroke, 2.3 times the risk of cardiovascular death, 1.8 times the risk of thromboembolism, 3 times the chance of type 2 diabetes, and 6 times the chance of end-stage kidney disease. Now, end-stage kidney disease is not that common, so it's not as horrifying as it looks, but it's still pretty horrifying. This is a really interesting slide, and it's done in Utah, so it may be just for Mormon women, but who knows. But this is a survival curve. So this is looking at time from the index pregnancy and with survival up the top. So the black line is those that had no blood pressure in pregnancy. The green line is those that had eclampsia, so fitted in pregnancy. The orange line is those that had preeclampsia in pregnancy. And here the worst are those that had gestational hypertension. So important to realise that it's not just preeclampsia, that gestational hypertension has a bad outcome as well. And closer to home, this study that was a data linkage study that Amanda was involved with as well, over 500,000 births in first-time mothers here in New South Wales, looking at their 10-year absolute risk of hospitalisation or death from a cardiovascular event. So the risk was 2.1 per 1,000 women if you didn't have hypertension, and 2.5 times that if you had hypertension in pregnancy. That risk increases over time, so it was 1.8 times at 5 years postpartum, 5 times at 10 years, and nearly 12 times at 15 years. But even more interesting than that, the independent risk factors were early onset hypertensive disease, preterm birth, which again is a marker of severe disease because in preeclampsia you deliver babies early because either the baby's sick or the mother's sick. Maternal age, smoking, social deprivation, but the really fascinating bit is that these risks were additive. So if you just had late onset hypertension, like the lady I was talking about, she had 2.5 times the risk. But if you had an early onset preeclampsia, you were a smoker and had a preterm birth, you had 49 times the risk of a woman who didn't have hypertension in pregnancy. So huge numbers. We get to our P4 study, which is a study we have been running now. We first started recruiting in June 2013, and Lynn hopes that we will have finished the 5-year follow-ups next year, looking at the physiology, maternal health, mental health, and paediatric health in a whole lot of normal women, because no one had ever really formally studied normal postpartum women. I know it sounds crazy, but they hadn't. And a whole lot of women with hypertension as well, and following them up at 6 months, 2 years, and 5 years. Interesting thing here, this is the results of their booking visit with their GP, and you can see that they have significantly higher BMI, significantly higher systolic blood pressure, and significantly higher diastolic pressure. But they were all significant statistically, but none of them were at a level that you would consider them to be abnormal when you were booking in a woman in clinic. Our main result, and really for me my main message, is that the upper limit of normal in the group of 300 women was 122 on 79. So that's 2 standard deviations above the mean. So 140 on 90 is really not the upper limit of normal for a normal postpartum woman. So looking at this table, so if you're using the old measure of 140 on 90, only 3% of them would have been detected as abnormal. If you use the new one, 13.3% would have had abnormal systolic blood pressure and nearly 19% would have had abnormal diastolic pressure. So 20% of these women. So what we're saying is 19% of women at 6 months postpartum are going to be abnormal, and we don't know, but we assume this is the group that are most likely to have long-term health risks. The other differences at 6 months, they had lower HDLs, higher triglycerides and a higher HOMA score, all suggestive of the metabolic syndrome, and that's all linked in with this, but we won't talk any more about that because you could spend all night talking about that. So, women who have had any hypertension in pregnancy are at an increased risk of later cardiometabolic disease. The risk is greater with more severe disease. It occurs early after a hypertensive pregnancy, so that means that if you do something, you can potentially alter that woman's health trajectory. Both women and their carers need to be aware of this risk, and we should be focusing on women with a blood pressure greater than 120 on 80. So there are about 300,000 births in Australia each year. 10% of them will get hypertensive disease, which is 30,000. 20% of those will have high blood pressure afterwards. So you get to about 6,000 women a year, which is still a lot of women, but you know, it's potentially a group that we can do something about. So that is the end of my talk. There are a lot of references there, which are available on the slides that Katie from the PHN will have, and I'd like to thank Katie and her partner in crime, Liz, who really helped us in putting this together. Thank you, Katie. So Katie will have the slides, and you're welcome to access those. I'm now going to hand over to my colleague Amanda Henry, who's also works with us at St George, and has done a lot of work. She's a clinical academic and has done a lot of work on what you do with this group of women, how you try and educate them and carers about their risks, their ongoing risks. So over to you, Amanda.
Thanks, Greg, and hello everyone in the room and online. It's lovely to actually come to see some people, to talk to some people in 3D. So after, I guess, what I might call the death and destruction talk from Greg, I have the risk is not destiny talk in terms of what can we do to prevent heartbreak after hypertensive pregnancy. In terms of disclosures, I've received various state, local and Australian government funding, but I have no industry or commercial funding, and I have no conflicts of interest to declare. So I think my part of the learning objective is to describe effective strategies to educate women about their increased risk of cardiovascular disease and diabetes after a hypertensive pregnancy. And I should acknowledge at this point that we don't yet know what the most effective strategies are, or necessarily the most effective strategies for various subgroups of women. Our group is very actively working on finding the answers, and we'll talk a bit about that. But there are certainly general principles in terms of what we know already that we can use. So in terms of what do we think is happening after hypertensive pregnancy and the intervention window that we have. So there's a couple of theories around the link between preeclampsia and hypertensive pregnancy and later health. The one, and certainly our data would support that these women actually already have an elevated risk preconception, and in some ways hypertensive pregnancy is kind of the Titanic iceberg above the water. The sort of physiological stress of pregnancy exposes these women's tendency to later cardiovascular and metabolic disease, which they already have. They're coming in a bit older, higher BMIs, etc. It's also possible, and certainly some animal work suggests it, although baby animals are not baby humans, that the process of having preeclampsia can also alter your vasculature, and that in turn increases your longer term risk. And look, certainly for, you know, the women who just really bizarrely, with no family history, normal weight, fairly young, etc., just get, you know, severe early onset preeclampsia out of the blue. I do think maybe that subgroup, there's something about having a hypertensive pregnancy that increases your risk, but mostly I think it's going to be the sort of preconception risk, and the pregnancy is kind of a stress test for your ongoing health in life. And then if you, as Greg sort of touched on, if you have it early, if you have it more than once, those kind of risks are higher again. And then if we do nothing about it, then women who've had an HDP history kind of track on and get cardiovascular disease in greater rates, but also get cardiovascular disease much earlier in life than women who have not had a hypertensive pregnancy. So again, traditionally, we kind of think about being female as a bit protective for heart disease, because women traditionally have had, get heart disease if they're going to get it 10 years later, older than men do. If you're preeclamptic or other hypertensive pregnancy, that advantage is erased. So on average, you will get your heart attack or stroke the same age, as a man would. So we've got this sort of window of intervention where we can prevent and hopefully sort of do something about it. And the other thing I just want to draw attention to is that this graph is adapted from an article in the British Medical Journal 20 years ago. And yet, we've still not made it much further along this path. We've been doing what I like to call admiring pathology instead of fixing pathology. So that's, I guess, what my plea is for. So in terms of what are our current recommendations and evidence base, there are various organisations, ISHIP, the Lancet Commission, the American Heart Association, that recommend cardiovascular disease and type 2 diabetes risk assessment and lifestyle advice after hypertensive pregnancy. It is true that the evidence is mostly extrapolated from what works for older adult populations. The estimate is that about 10% reduction by those lifestyle and risk factor changes, which I guess doesn't sound like much, but when you consider that heart attacks and stroke are two of the three sort of top 10 causes, two of the three top causes of death, and type 2 diabetes is another top 10 cause for women, then 10% reduction matters on a population level. A review that one of my registrars, Nicola Louis, did a couple of years back found that yes, there's modest evidence for online-based lifestyle programs. We do have questions remaining about whether it does enough good equitably. We'll get to that. One of our big problems is about assessing risk. So traditionally, GPs and healthcare practitioners use sort of the multivariable risk calculators that come out from organisations like the Heart Foundation that assign an approximate risk to individuals without established cardiovascular disease. And many of these are at least partly based on the Framingham studies from many years ago. So Australia, the Heart Age Calculator, the Australian Absolute CVD Risk Calculator. No commonly used calculators, although there's been lots of talk about it in recent years, but it hasn't happened yet, adjust for pregnancy and reproductive factors such as hypertensive pregnancy or gestational diabetes. And just to give you an example, and this slide is thanks to, from my colleague, Professor Claire Arnott, cardiologist. So Mrs. PE is a 45-year-old non-smoker. She's had 2 prior early onset preeclamptic and gestational diabetes pregnancies. She has a strong family history of mother and 2 maternal uncles having a heart attack in their 40s. She's of high BMI at 32, but she has normal resting blood pressure and fasting lipids. She has impaired glucose tolerance, but she doesn't have type 2 diabetes, and her resting ECG is normal. So by one calculator, she gets a 0% risk of heart and stroke in the next 5 years. And the Heart Foundation said, okay, your heart age is 4 years older than your actual age, but is still really not bringing home the risk that we know she has. This woman really does not have a 0% risk of developing cardiovascular disease in 10 years. The work that Claire and I, among others, did with the New South Wales Health data has told us that. So in the absence of a reliable risk calculator that you can tick some boxes and give to the woman, practical points, checking on her history, including smoking, we were really quite startled by the sort of multiplicative effect of a smoking history in that New South Wales Health data. Weight, waist circumference and BMI, blood pressure in clinic. Doesn't have to be the liquid crystal sphygmo for the non-pregnant population. Automated ones done several times will be fine. Lipids and HOMA score, so for insulin, or if she had gestational diabetes, then really should have a full GTT, of course. And then some lifestyle behaviour change counselling. And this on the left, which I'm happy to share, we are using in our current blood pressure postpartum trial, and we've adapted it from the P4 results that Greg was talking about in terms of you're above the line if your systolic blood pressure is above 120 or your diastolic's above 80. Get another tick if you're in the higher weight range. If your HOMA score was more than 3, etc. And so with the women that we have in this study, and I think it's a useful ongoing counselling measure, it's a green traffic light if all measures are within the normal range or similar to postpartum women who didn't have hypertension in pregnancy. That doesn't mean they've got no cardiovascular risk, but it is reassuring that their only risk factor is that they had high blood pressure. An orange traffic light's one measure outside, and 2 is more than one measure. And for those in particular, I would suggest, considering early initiation of medications or more regular early follow-up or potentially referral to specialists. The Heart Foundation has done a fair bit of work in this space, and there are resources available for healthcare professionals, which are, again, I hope potentially quite useful, and emphasises that as well, it's also sort of preterm delivery and did the baby have growth restriction, and giving advice about sort of checks to do. Lifestyle behaviour change is hard, particularly soon after pregnancy when mum's needs often come last. A couple of things that I think are potentially of practical help. So I mean, it's quite common, of course, when we're talking to women about nutrition and improving the diet. Well, I've got no money and no time to do that. It's expensive to eat well, and it costs too long to cook the recipes. So Professor Claire Collins is an academic dietitian at University of Newcastle. She's for many years worked in improving this space, and she has a freely available nomoneynotime.com.au, which has got, the last time I checked, more than 250 recipes, which are affordable and healthy. In terms of exercise, I think Greg, with his slide, made the sort of pointed out that you only need as little as 20 minutes per day of moderate exercise to make a difference to reducing your preeclampsia, gestational hypertension, and GDM risk next time around. And of course, that's going to be helpful ongoing in life. Look, everybody knows the GPs in particular know the stuff better than I do about quitting smoking. And look, another resource, not for everybody, but there's telephone and online lifestyle behaviour change counselling, the Get Healthy service, which is freely available to New South Wales residents. And they do also now have tailored programs both for pregnancy, and I believe they've developed one for sort of early childhood in the first few years after birth as well, which is great. So then in terms of trying to close those knowledge gaps, the picture is of now Dr. Heike Roth, who's midwifery academic at UTS in Sydney, and who I had the pleasure of co-supervising her PhD, which was all about seeing what do Australian women and what do their healthcare providers, including GPs, FRANSCOGs, midwives and cardiologists know about health after hypertensive pregnancy? Where are the gaps, and what do women and healthcare providers want in terms of being able to counsel for the healthcare providers, or being told and when for the women? And she did both surveys and interviews. So there's lots of similarities actually between the women and their healthcare providers. People sort of tended to have reasonable knowledge about, there's maybe some risk of chronic hypertension or a bit of a risk next time around for the pregnancy, but very little understanding that it's more than just preeclampsia, so that the gestational hypertension, so high blood pressure only, in inverted commas, in pregnancy actually carries substantial longer term risk. Not much understanding about the interaction with things like diabetes, and also that risk actually starts to rise quite soon. You don't get a 20-year free kick on this stuff. Women would like knowledge in the first 6 months, and then sort of some immediate knowledge, so that's our responsibility before they go home from hospital, but then a booster later on when they're kind of ready to process. And there's often, significant sort of traumatic symptoms or postnatal depression or anxiety to get over before women are able to get to processing their hypertensive pregnancy experience and what can I do now. And women do want, however, although they're really both GPs and the women would like some written info, they'd like website information, supplements, to supplement stuff or to help with counselling, but women agree that at the end of the day they want their real live doctor to actually talk to them about this stuff and to be looking after them. And both women and healthcare providers want more structured follow-up, so not that kind of postpartum black hole that everyone really in some ways seems to go into, not just women who've had a complicated pregnancy, and better hospital to community transition. So we are now running pilot programs to try and close that gap. So at St George, about to start at Liverpool, and we'd be very happy to bring it to Orange as well, or any regional centre that's interested. For the women's program, we're enrolling anytime in the first 6 months after birth. They do baseline knowledge survey and then follow up 6 months, 12 months. Get access to a specific post-hypertensive pregnancy health information website that we've built, and an app that Claire Arnott and colleagues have built. And then they get reminder letters at 6 months about seeing their GP to discuss these issues. And we obviously get the details of the GP or GPs that they might see, and send that GP Heart Foundation information and access to the website as well. And we're also planning to interview a group of women. And this is just to show you what the kind of front page of the website looks like, which we've also got in Arabic and Mandarin. That's two of our most common non-English speaking languages in our area, and some of the topics that we that go through on the website. So in terms of preliminary findings, so far we've had 25 women enrolled. We're hoping for 100 in the pilot. Low knowledge of how soon the risks rise, but it had improved for those who've gotten through to the 6 months. The most accessed website topics: effect on children, on subsequent pregnancies, and when timing of things might start to happen. 1/3 indicated that they didn't believe they'd had any risk discussion before they entered the study, and this is despite the fact that all of these women are from St George so far, and so I know that they've enrolled from a centre where we routinely, or we think we routinely discuss future risk, but there's still 1/3 of women who indicated to us they'd gone home without any of this information. We're also proposing pilot program for GPs, and I've actually just been discussing with our central and eastern and southern Sydney PHN in Sydney about getting practices on board for that, to try and trial an improved hospital to practice postnatal handover, helping with that educational materials and the 6 to 9 month visit checklist via sort of Health Pathways portal, some practice in services, and also before and after surveys. And then in terms of trying to get better evidence in terms of management, more kind of specifically what works and who is it best for, we have been doing the blood pressure postpartum study. And so in this study, basically in the first year postpartum, we're trying to compare the effect of what we've called optimised usual care, because it's not quite a control group, a brief education intervention and an extended lifestyle intervention on maternal blood pressure, on lifestyle behaviour change, on various risk indicators like the insulin resistance, etc., and a bit about baby as well and healthcare costs. And so the three arms. Essentially, we've run this at 6 Sydney hospitals, which you can see along the screen, and we've tried to be as inclusive as possible. So we've had, interpreters available to translate and to get any non-English speaking background women into the study as well. Really, it's just those who had suffered a loss, who we knew we couldn't follow up or had severe mental health disorders. So we approach them before they go home, ideally, but confirm consent by 5 months, by which time most women are kind of ready to take things on board, do some questionnaires, then they go into one of the 3 arms and have a 6-month visit and various blood and urine measures, and then at 12 months we're looking blood pressure, weight, waist, circumference, and the various other clinical and blood measures. And so the 3 arms, so the optimised usual care is sort of GP based. So seeing the GP at 6 months for a blood pressure check, a baby check, getting the information pack, including from the Heart Foundation and about the Get Healthy service, and sending information again to the nominated GPs. And we didn't call that a control group because we actually think that's probably better than what routinely happens at the moment. So, but this is what national and international guidelines recommend. So we didn't really feel we could enrol women into a study where we randomise them to less than what guidelines actually recommend, even though we know it's not really happening. Brief intervention, they come to that visit, but it's at the dedicated postpartum clinic at the study hospital, and they see a physician and a dietitian, and we use the P4 data tick sheet that I showed you before for counselling. And the extended lifestyle intervention is we actively enrol them into the Get Healthy service after that 6-month visit. So then they get a sort of the 6-month telephone-based lifestyle behaviour change program. So far, I'm very pleased to say we have recruited 100%. So we've done our last 6-month visits this month. I will have the data for you in the next year. We have managed to recruit diverse participants, so over a third are overseas born or non-English speaking background, reflecting our diversity of population in Sydney, so that's good. On the downside, only about 1 in 4 potentially eligible women actually enrolled, which, to be honest, is pretty similar to many other pregnancy and perinatal trials, but it will raise a question mark about how generally applicable it is. We've got permission from the Ethics Committee to look at the women who were excluded or didn't sign up for whatever reason, so we will at least be able to compare the basic pregnancy and demographic characteristics there. We're not done by group because, of course, we can't unblind ourselves yet, but we have had a bit of a look, and there is a modest but significant blood pressure and weight drop between 6 and 12 months in the overall study group of sort of at the halfway mark. And the interviews that we did suggest that we really do need structured intervention. So basically women were quite happy to do the study, and particularly if they were in the extended lifestyle intervention group, they were very happy with that and told us all about, how useful that was and the coaching, etc., etc. But almost no one in the other 2 groups enrolled themselves into the Get Healthy service extended intervention, despite the fact they were perfectly free to do so. So that kind of suggests to us that women, we do need to provide structured intervention and sort of checkpoints and checkups. Women aren't going to find that themselves. So in terms of future directions, I guess the known unknowns, yes, we do need to understand more about the pathophysiology. We do need a better, simpler way to predict outcome and individual risk. There will definitely be a group that needs pharmacotherapy. Even if like BP squared does show that there's a decent overall drop, I'm under no illusions that that's going to be enough for a subgroup of women. But we need more information about what we would use and for whom, because, obviously starting women on lifelong medication is quite a big deal, especially when they might be having more kids. And I think we really need sort of a systems change to, go from thinking about maybe a shared responsibility and handover. Obviously from the hospital side, we need to get a lot better at comprehensive information, discharge back to our primary healthcare colleagues, maybe using primary healthcare network structures to do that. whatever works for our GP colleagues. And I wonder also whether we will find that some ongoing involvement from the hospital and community maternal and child health services in the first 12 months, like a postpartum clinic or using maternal health screening at routine child visits, might be kind of part of this, that we gradually hand back to their family doctors who'll be looking after them for the rest of their lives, hopefully. Just to also emphasise, ultimately this needs to be holistic, it's not just heartbreak after preeclampsia, gestational diabetes, hypertensive pregnancy more generally, those who've had a very growth restricted or preterm baby for whatever reason. It all runs together with increased risk of cardiovascular and metabolic disease, and very important not to neglect mental health, and to try and build on what systems that we do have. So, you know, there are currently GTT reminders after gestational diabetes that the Australian Diabetes, I forget the name of the peak body, but are sent out. We can adapt that to this as well, or complex pregnancy more generally. And yes, I just want to finish my plea for action to improve women's health after complicated pregnancy, to stop admiring the pathology and start treating it by understanding the risks, communicating these risks to women. So for us at the maternity healthcare provider end, we need to start pre-discharge and then communicating to our healthcare provider colleagues, assessing and ensuring assessment of women's cardiovascular risk factors, and you know, so BP thresholds no longer 140 and 90, and below that you're good. We do need to promote risk reduction through lifestyle behaviour change. Even if it's only a 5 to 10% risk reduction, that will save many lives on an ongoing basis. And yeah, I work in a wonderful village of our obstetric medicine research group, our various colleagues at other hospitals, consumer group, APEC, and many thanks to our state and federal funders. Thank you very much. Are you going to
Yeah. Thank you, Amanda. And I'd like to, last of all, just invite Professor Emad El Omar up. Emad is, it's going to be a change of pace. Emad is a gastroenterologist and a bit preoccupied with the gut, one would have to say. Not surprisingly, really. But he's been working with us in our research group, looking at the issues of gut microbiome in pregnancy and in pregnancy-related disorders, and has some very fabulous slides for you to look at. So, Emad.
Thanks, Greg, and good evening, ladies and gentlemen. Thank you so much for giving us this opportunity to visit you in Orange. Thanks to Madeline for allowing this to happen, and for the Primary Healthcare Network for facilitating it. To Liz and Katie, thank you so much for helping us out. This is not my slide, but no, I'm just kidding. So now for something completely different, which is the kind of the gut contribution to all of the things that we've discussed. Obviously, you might be thinking, what the hell does a gastroenterologist have to do with pregnancy and with pregnancy outcomes? It's very important to remember that the body is not compartmentalized. It's not just you've got the gynecology, you've got the obstetrics, you've got the heart disease. It's all the same system with different themes, but the fundamental processes are the same. Microbiology, immunology, genetics, all of these things apply. So I think this is why it's very important to work together. And I think I'm very fortunate to work with with Greg and Amanda and our renal physicians and the nutritionists and the midwives for the obstetric medicine research group at St. George, because you learn so much, and I think that feeds into your contributions to understanding of medicine. So this is a very wise guy, Hippocrates, father of modern medicine, who said that all disease begins in the gut. Very far-sighted observation, and I think it's over the, like millennia, we've had these kind of things confirmed. The microbiome story came along really in the last kind of 20 years or so to confirm that suspicion from many, many years ago, and provide the mechanistic insight, plausibility of why the gut is relevant to all of these kind of different organs. Now, I'm sure you all know about the microbiome, and more importantly, your patients that come and see you in the clinics are very, very savvy. They've all heard and read in the magazines and newspapers and so forth about the microbiome and gut health. You've got celebrities jumping up and down, advertising yogurts and stuff. So I think it's important for us as healthcare professionals to have some kind of working knowledge of the microbiome and staying kind of on top of things and updates and so forth. So we talk about the microbiota, these are the bugs, the trillions of microorganisms, but we also talk about the microbiome, and that's the genetic kind of constitution, that's the collective of all of the genomes and probably their products. So I think it's kind of a more comprehensive term. It's incredibly important because we're outnumbered, so there are more microbial cells than human cells. It's equivalent to the liver in terms of its metabolic output. I mean, this is a staggering statistic. It's just like, imagine this industrialized zone in your body, the liver, and this extra organ, the microbiome, is actually equivalent to that output, which is very impressive. It weighs as much as your brain. So I think it's another kind of interesting fact. So your microbiome is as much as your brain. Depending on what your microbiome composition is, there's a lot of jokes that can be said about this. Now, suffice to say, over the last 10 years or so, there's been lots of studies published about associations between the microbiome and lots of conditions: hypertension, cardiovascular disease, strokes, diabetes, cancer, inflammatory conditions, all of these things. And there is no doubt that those studies have been confirmed, and we can now move on from association to actual mechanistic studies that would show that this is a relevant contribution. They're key to many aspects of human health: immune, metabolic, and neurobehavioral. And indeed, when we talk about the microbiome, we've got to explain the plausibility. You've got to provide the reason why this is relevant, because then you have an opportunity to prevent preeclampsia or gestational diabetes or obesity. These are all very important. Now, at the heart of it, in terms of mechanisms, it all boils down to this interaction between the outside world and the inside, us. And what separates us from the outside is usually mucosal barriers or layers that essentially have our immune system just behind, waiting, trying to kind of fight off any invaders and prevent the activation of the immune system unnecessarily. But equally, you want to allow certain things to come through to educate the immune system and to derive products that we can't synthesize. So this microbiome then that lives just above that layer is very important from that point of view, because it metabolizes things that we can't digest. We cannot metabolize fiber, for example. So they do that for us and generate short-chain fatty acids, which have a direct impact on our immune system. So they can dampen the immune system. They can actually find that perfect balance of enough tolerance but preparedness against any invasive microorganisms and so forth. So from that point of view, it's very important to have the right mix of microbiota, ones that can do these functions without overreacting. Equally, if you've got invasive microorganisms, you want an immune system that is able to kind of jump in and try and save you as a host. Obviously, this is all about balance and equilibrium. So if you've got the right mix of microbiota, they can keep under control all the pathobionts. More importantly, so by producing the local kind of antimicrobial products, they can keep them under check, but also protect us against antimicrobial resistance. And this is a very important emerging theme, which is going to be a big challenge to humanity, is the lack of antibiotics and so forth. So the microbiome does that function if it's really quite nicely balanced. If you lose that balance because your diet is bad, you don't exercise, you're taking lots of toxins and so forth, then you tip it towards the pathobionts and the onset of a state of chronic low-grade inflammation. And that's usually kind of there's an inflammation that then weakens that barrier. It becomes leaky, and then you start to translocate all those bad products from the outside into your system, and then they can go through the systemic circulation, through lymph, and so forth, and then obviously exert their effects really quite far away. Quite often, we don't really know what's the chicken and the egg. This is the eternal question in medicine, which came first. Whatever it is, you end up with chronic inflammation if you've got dysbiosis, this imbalance kind of situation. And chronic inflammation is the root of all evil. It's at the heart of every condition, whether it's cardiovascular disease, whether it's cancer, whether it's obesity, whether it's preeclampsia or gestational diabetes. All of these things have chronic inflammation at the heart of them. And there are many, many causes, of course, of the dysbiosis, and I'll mention a few in the next few slides. But this just explains to you why, if you've got this imbalance in your gut and having that weakened barrier that is leaky and the translocation why it becomes relevant to the brain or to your vascular beds or to the placenta, for example, or the kidneys. All of these things become, this is the kind of a plausible mechanistic pathway. Now, the hub of all of this, the actual importance of the whole story is about the metabolites, the metabolomics. So this is what so that genetic power that the microbiota has, it's all about generating products, and these metabolite, proteins, and then the metabolism of precursors, and you generate lots of moieties that are either anti-inflammatory, neurotransmitters, receptors that activate metabolic pathways and so forth, things that influence your mood, but it's all about metabolomics. And this saying that we are united in biochemistry, that explains why if I analyze your samples today, everybody is going to be different, okay? If it's based on just the classification, the taxonomy of your microbiota, it doesn't tell us much. But if we do another omic, we have another omic, the metabolomics, that gives us a far better direction in terms of, are you actually in a good place or in a bad place? So I think that's why we're all united in biochemistry. Sometimes there's a bit of redundancy and duplication, and if you do the metabolomics, it actually tells you a lot more. I mentioned this, the gut-brain axis, because it's really the most fascinating, and perhaps ultimately it might be the most impact. We're all aging, the risk of dementia is increasing, mental health is a big issue in most societies, and you've got to remember that the gut is actually the largest nervous organ outside of the brain. It's the largest immune organ. 70% of your immune cells are in the gut. It's the largest endocrine organ. So all of the relevant systems are actually concentrated in that organ. And the gut is directly wired to the brain through the vagus nerve, and things move up and down. You can translocate things actually up the nerves. You're communicating through cytokines and immune products, with the rest of the immune system, and you're also generating neurotransmitters. You're generating, inflammatory products that have direct effect on the brain. So there's nothing more interconnected than the gut and the brain. Actually, it's absolutely fascinating, and that is why every time there's a gut problem, you're miserable. Your mood is bad. If you've got constipation, you're miserable. If you've got diarrhea, you're miserable. And it's not just because you have a psychological predisposition to this. It's actually physiological. Something has gone wrong because of that kind of connection. And that's, of course, relevant to pregnancy outcomes, because postnatal depression and these kind of outcomes that are really cause a lot of morbidity could also be explained by this gut-brain connection. I think it's very important. You're familiar with the pathways for generating serotonin. Serotonin is the feel-good hormone. And it's all to do with the microbiota. So, they directly impact on the generation of the serotonin ultimately. This is just James Brown and his famous song about it. Now, many things impact on your microbiome composition. This is relevant to preeclampsia, but very relevant to pregnancy outcomes, because it's happening all the time. The most important is diet, of course. It's what you feed your microorganisms in your gut. So whatever we can't digest, we're dumping there. And then they can munch away at these things and generate things that could be good for us. Equally, if you're eating a lot of fat, meat, red meat in particular, and so forth, these can generate the wrong metabolites and can have a very, very bad influence. From the moment of conception, and even before, as I'll mention later, there is an effect of the microbiome on the developing fetus, as well as on the, obviously the mode of delivery is very important, whether it's cesarean section or vaginal delivery, as well as the mode of feeding, so breastfeeding versus bottle feeding and so forth. These all have a major impact on the gut microbiome. The other thing that we are all guilty of as healthcare professionals is medications. We're all dishing out medications. We write these things very, very, obviously well-meaning, but remember that it's not just antibiotics that can have an impact on your microbiome. It's actually non-antibiotic medications. There was a fascinating study published 2018 that looked at 1,000 drugs that are non-antibiotics and found that a quarter of them will kill off quite significant proportion of your gut commensals, things that actually work for you. And this explains all this kind of bizarre thing about, why does somebody get diarrhea? Why does somebody get headaches as a side effect? Why does somebody, get nausea and vomiting and all these inexplicable things? Now we're kind of starting to understand why that's the case. So just medications, and one of my kind of most important things that I'm really just as one of Greg's bugbears is proton pump inhibitors, PPIs. We prescribe them, massively. 10 to 15% of the world's population are on PPIs. It's absolutely staggering. I mean, it really is. And they have the most profound effect on the gut microbiome, and in fact, direct bactericidal effect, and in fact, cause a dysbiosis. This is established beyond doubt. And it's not a surprise that you're seeing, reports coming in, it increases the risk of this, risk of that, cancer, diabetes, all of these things are all related to that, medication and so forth. Right. Now, the effective diet, of course, now you look at the healthy diet. The definition of healthy is not any particular fad diet or anything. It's just it's got enriched with plant-based products. So the variety, the diversity, the color, and there have been large studies that have shown that, the populations that consume a large number of plant-based, fruits, vegetables, legumes, nuts, all of these things correlate with a very diverse, healthy microbiome and with health outcomes, reduction in chronic inflammation, enrichment of short-chain fatty acids, and so forth. In contrast to a typical, like a Western diet, which is mostly carnivorous with a lot of red meat and fat and so forth, the exact opposite in terms of the microbiome and the metabolomics. So we know this is very important, and this is relevant to pregnancy, of course. Then we come to pregnancy, and I think this is a situation where it's all about protecting the species, isn't it? Like that's the biggest function of any species, is to produce successfully so that you have a healthy next generation. And there's a lot of debate about whether the microbiome is relevant to the in utero environment. In other words, does it start right from the beginning, even in the development of the placenta and what the uterus, the fetus is exposed to? I would say we haven't heard the last word. There's a lot of people that believe strongly, this is just a lot of rubbish, this business is sterile, all the signatures that you're getting are all just contamination by the molecular biology or agents and so forth. Keep an open mind, because the act of conception is not sterile. It's actually got plenty of exposure. And there's no reason why those tissues that are developing will not retain some kind of microbiota as the fetus is developing. Could impact on their physiology, could impact on the brain development, who knows? Keep an open mind. But whatever it is, I think there's more and more evidence now. This is a very interesting study published last year that analyzed human fetal tissue and the placenta in the second trimester of gestation. These are human tissues. And in fact, I identified live bacterial strains that were able to induce activation of memory T cells in the fetal mesenteric lymph nodes. And this is the first kind of direct evidence that there is an actual microbiome that has an impact on your immunology. I think this is, and so all the skeptics about, oh no, this is sterile, have kind of found this a little bit difficult to digest, and there's a lot of debate about it. Whatever it is, I think it's very important to remember that the mother passes to the baby quite a big chunk of its microbiome. And if the mother's microbiome is dysbiotic, for example, if you take patients with inflammatory bowel disease, the archetypal dysbiotic condition, and you take the poo from the babies and you put it in a mouse model, you're actually transferring those immune abnormalities to the animal model. In other words, those are disrupted. This dysbiosis that came from the mom has impacted on the immunology of the babies. And I think this is very, very powerful data. If you're interested in the development of the microbiome, this is a beautiful review published just a few weeks ago. And this is looking at all the different inputs of the baby's microbiome as it develops, from mom, from siblings, parents, whether you've spent time in the hospital, the mode of feeding, your pets, which actually contribute quite significantly also, and have also been correlated with a better protection against chronic diseases and so forth. Fascinating work that is being done at the moment. So I think this is a really nice review. The take-home message from that particular study is that maternally acquired strains were more persistent than those acquired from other sources. So mom is very important to the baby's health and the microbiome development and future health of, obviously, the global community. Very nice work. Now, is there any evidence that the microbiome is dysbiotic during pregnancy? And could we predict adverse outcomes? So we've talked about preeclampsia, hypertensive disorders. This was a very nice study published a couple of years ago. So what these researchers have done is that they've taken a reasonably large number of women that developed preeclampsia. They took their poo and they analyzed it and found that it was dysbiotic. And then they transplanted it into mouse models. And recreated the preeclampsia phenotype. In other words, if you just give them the poo, they develop preeclampsia, which is, you know, quite fascinating. Now, we don't know for sure if this is happening, you know, in humans or not. Suffice to say, there's been a lot of interest in this and a lot of interest in other outcomes like gestational diabetes. All of these studies now have moved away from just describing what's happening into trying to figure out the mechanism and trying to intervene. So I think this is a very, very hot area of research. Just note the word, this was during pregnancy, okay? So all of this stuff is being described during pregnancy. No one is talking about preconception, which ultimately is what we're after here. Now, there was a very nice commentary on this, or editorial in JAMA about this paper, again published a couple of years ago. Again, if you're interested, if you just want to find out a bit more, this is a really nice reference. It's not just preeclampsia, gestational diabetes is the other one. And again, you know, there's been a lot of work on this. Amanda and Danny and Greg and you know, in collaboration with us at MRC have done the MUMS study. This is looking at the microbiome in maternity, and showed similar findings in the first 100 women that delivered. Those that develop gestational diabetes have a dysbiotic signature. There's a paper just about to be published. I'm the editor of a journal called Gut, so I have my pulse on the, my finger on the pulse, as it were. So, you know, really fascinating work working out the mechanism again of how this gestational diabetes signatures actually work. Does it, you know, what the mechanism is? It's really fascinating stuff. So you'll be hearing a lot more about this in the next few years. Now, ultimately, however, it's all about what can we do about this. I mean, it's okay, so the genomic revolution came and we could predict the risk of this cancer or that cancer, but what the hell can you do about it? You're stuck. You're basically, you can't change your genes. The microbiome is imminently manipulable. You can change it in many kind of ways. Most importantly, through diet, sustainably through diet, by, you know, adopting a healthy diet that you start on and you stay on, and while you're on it, your microbiome will always be balanced and diverse. So I think this is, okay, it's difficult to do that, but there is an answer. I mean, I think we can actually change it, and you can change everything. You can change your epigenome. These are the changes in the genetics that can impact on the pathogenesis of disease by dietary manipulation. Exercise, even just exercise on its own, just physical activity. As you know, physical inactivity is correlated with every other ailment in humanity. You know, cancer, diabetes, obesity, all of these things are influenced by lack of physical activity. Lo and behold, if you're active, your microbiome is diverse, over and above what it is from the diet. Okay, so if you run a marathon, obviously you're preparing for it. Before and after, there's been a study published in Nature Medicine showing that, in fact, your metabolites are different, and they actually enhance your performance just because you exercise through the microbiome. I think this is really kind of fascinating. There's a lot of stuff on probiotics and prebiotics, and maybe we can discuss that in the questions and answers. Things like symbiotics, that's a combination of two. The two postbiotics is saying, well, forget the bugs. What about the stuff that they produce? Can we just package short-chain fatty acids and give it as a, you know, as the product? Not much progress there. I think it's a little bit difficult. For one, short-chain fatty acids are absolutely disgusting to take orally, just absolutely foul. Antibiotics, sometimes they work like rifaximin. You prescribe rifaximin for IBS and so forth, or hepatic encephalopathy, again, working through the microbiome. And finally, FMT, fecal microbiota transplantation. I'm sure you'll have patients coming to your clinics asking for, doc, you know, should I have an FMT because, you know, I have depression, or I have, you know, my son has autism, or, you know, diabetes, or whatever it is. So there's been a lot of interest. This is an ancient concept. You know, this goes back, you know, really millennia. And if you watch the animal kingdom, if you have a dog and you're walking the dog, the bastards are always trying to find other dogs' poo, isn't it? And then they go and just enjoy eating it. And I think it's just, this is actually telling us something, that this is a way of enriching and diversifying their microbiome. And somehow it's probably actually a good thing. Whereas we all freak out, my goodness, you know, this, have to take him to the vet for a washout or whatever. So this FMT, if you get somebody else's poo and transplant it into your gut, it does work for one condition perfectly, and that's a C. diff infection, because you're replacing not necessarily a dysbiotic microbiome, but one that is enriched with one particular bug that produces a toxin. So it's an easy one. You can just flush it out, and it works beautifully. If you've failed your vancomycin, if you failed your expensive stuff that, you know, costs, you know, $4,000, $5,000 for doxamycin, and then you can use FMTs, but we don't have it available, unfortunately, readily here in New South Wales. I think you can get it from one place, but it's not available. But for everything else, it's still experimental. Okay, there's been lots of reports about, for example, depression. There was was a lot of publicity a few weeks ago, a few months ago maybe, where there were 2 cases, really intractable depression. They had an FMT and they were completely transformed. This requires clinical trials, and there are over 300 clinical trials at the moment on FMT in every conceivable condition. So it's encouraging. It's not the answer, because ultimately we don't want to be giving poo to everybody, but we want to be giving whatever it is in the poo that is actually doing the good things. So for example, a consortium of microbiota that are intelligently gathered together and packaged in a way that could actually have an impact. So unlike these capsules, which is what's actually become very, very popular. In fact, this is actually probably the official term used for describing these things, the capsules. They're produced in Canada. I think there is a place that produces them here. But as just common sense, okay, it depends on the donor, doesn't it? If the donor is superior, one of the descendants of the gods, and they've never had antibiotics and delivered vaginally and breastfed and exercised 10 hours a day or whatever, they might be good donors, because they'll have a very, very healthy microbiome. But if you get somebody who's not, and this has happened, I mean, there are cases where a mom has given the daughter FMT because of C. diff and transferred obesity, for example, as a problem, or depression. This has already been reported in the literature. So I think we've got to be careful. I think we've got to do a lot more work to refine this into something that we could employ, for example, in pregnancy, or preemptively before pregnancy. Now, what I'm basically, this is just personal microbiome testing. If you want to ask me about it, I'll answer it, but I think I'll just skip through it quickly here and just come to the main issue here, which is all the work that we've talked about happens during pregnancy, but we're desperate to do something about it before it happens. And there isn't at the moment anything that you can do, anything that you can test to tell you this patient is going to develop gestational diabetes, this one is going to develop preeclampsia. So ideal situation is the preconception. You want to do something. If somebody is planning a pregnancy or thinking about having a baby, that's when we want to find out if you could predict that risk of any of these complications. Okay, and this is why we're obsessed with this study called the MothersBabies, and Naomi is our executive officer and the project manager, doing the world's most difficult study, recruiting women who are planning to have a family, actively, hopefully, and then we do this longitudinal study whereby we take samples, stool, vagina, skin, oral microbiomes. We take some blood tests. We get a handle on the genetics. We take samples from the partners, and we follow them up every 3 months. We do these kind of tests, every 3 months, not the blood, just the microbiome samples, until they conceive. And then we continue sampling every 3 months until trimester 1, trimester 2, 3, and then up to a year or two beyond the postpartum. And of course, the babies also get the same samples. It's the most exquisite study. It's the most brilliant study, but it's the most difficult and expensive study to do. But thanks to all the efforts of Naomi and her team, I think we've recruited now close to 500. And the first 100 babies, 104, 105 babies have been born. And there's another 107 women who are pregnant. So, we're off the ground. We've recruited a quarter of what we're actually after. But you can imagine the treasure that this is. It's just trying to get a handle on everything before the pregnancy. And, you take all sorts of data, all sorts of measurements, in addition to this microbiome business, so you can actually put them all together and try and figure out who really develops those outcomes and whether we can preemptively manipulate the microbiome in a positive way, the same way as I've described, to try and prevent or reduce that risk. This is ultimately what we're trying to do, and we count on your support, and we'll be absolutely delighted if we are able to recruit from rural and regional Australia, because we don't want all our kind of information to come from cities. This is it's a bit skewed and misleading. So we want as comprehensive a collection as possible, and it is a national study. So we're recruiting from every corner in Australia, and I think with your support, and hopefully we'll do this in other regional rural areas, we'll try and kind of enrich the study so that it's comprehensive and diverse to give us those answers. And with that, I thank you for your attention. Thank you very much. Just sit there.
We are, so we really want to recruit some country poo as well, so that's what you guys are here for. Super donors. Miguel, yeah.
Question for Eman. What's your take on vagina for
Yeah, so that's, I mean, you know, the concept sounds like it's a reasonable thing. Obviously, assuming you're not transferring any kind of infectious diseases or anything, you know, it sounds like it's a reasonable thing, but you've got to do it in a clinical trial. And I think the best thing that I can tell you is that there is actually a clinical trial that is ongoing at the moment. Professor Maria Gloria Dominguez-Bello, who's the world champion in this kind of situation, she's just, you know, doing this largest study that's ever been done. I think it's a controlled trial. However, I mean, I honestly think, you know, the passage through the, you know, the vagina with natural birth is quite a protracted process. I mean, it's not like you know, dab it and then just put it. So I just wonder how much you're transferring in that process. But I would love it if that works. I mean, I think if it turns out that, in fact, you know, in the clinical trial, that doing something as quick as inserting a, you know, a swab and then leaving it there and, you know, whatever, and giving it to the baby's hands and face and the rest of it, if that works, great. You know, I'm open-minded about it. As long as you're not transferring any infectious diseases, I think you've got to have that kind of thing. I don't know if anyone else wants to, you know, the obstetricians, yes.
Oh,
yeah.
Yeah, it needs to be looked at in clinical trial circumstances, and I certainly wouldn't recommend it as risk-free until and unless we have trial information that it works.
Yeah, the trial is ongoing. I think it will report.
And there are so many things in medicine, I feel, that it kind of makes sense, but, you know, there is a logic behind it, but, you know, that doesn't make it true. And
yeah, antioxidants to prevent preeclampsia seemed to make wonderful sense 20 years ago, and then a, you know, big randomised controlled trial was done to show it was useless. So,
yeah. Anyone else with a question?
it looks like there's quite a few in the chat.
Don't prove? Yeah, yep. Oh, no?
No? Oh, okay.
Can I ask a question involving the partner of, we discussed this in the earlier one. How important is it with the research that you're putting together and Naomi's running, how important is it to have a partner involved?
Yes, so that's a very important question, and I think that Naomi, with the study, I think 50% of the participants so far have agreed, you know, the partners have agreed to donate the samples. I think it provides unique knowledge and opportunity, because the making of that embryo started with two people that have contributed something to that niche, right? I mean, it wasn't sterilized by a postdoc, irradiated everything and said, now, you know, happen. So if it was done correctly, I think it would be a pretty rich, you know, environment for microbiota to be there. So the partners is obviously relevant. I mean, you know, there is seminal microbiome, so there's bugs in the semen itself, and who's to say that this environment is not actually inhabited in a very low biomass kind of way? We know this happens everywhere. There's nothing sterile in the human body, so it may be relevant. And having a handle on that one is very important for understanding, you know, what happens to this baby as it develops, both as a fetus and then as a child and then into an adult. This is unique. I think that's why it's so important to try and get as many as possible, to try and provide as many answers as possible.
What about donor sperm, you mean?
Yeah, no, I mean, there is a microbiome associated with it.
Oh, okay.
Yeah, absolutely. Yeah. I mean, you know, in fact, some of the studies we're doing at the MRC, collaboration with the Chinese University of Hong Kong, is all about male fertility and, you know, that kind of stuff. It's you know, it's relevant. You know, you're injecting something that is not sterile.
So there's one question here. It's from Tina. Amanda mentioned women with hypertension in pregnancy were interested in knowledge regarding associated risk to their child or baby. As clinicians, what do we advise to the mums on this? Is there much information available?
Okay, so thanks. So that was about how the women in our studies have been really interested in knowing about risk to their child and what do we know. So excellent question. less than we know about the women's risks is probably the first thing to say. There certainly big, and some of the Adelaide group have done quite a bit of work pulling this together. There's certainly sort of from meta-analyses of various observational studies, children after hypertensive pregnancies by sort of late childhood or adolescence do have overall higher weight and higher blood pressure and more of a tendency to insulin resistance than children of normotensive pregnancies. And I mean, some of the original like Barker hypothesis developmental origins of health and disease was actually, you know, in like growth restricted babies, including post-hypertensive pregnancy, so showing the kind of later adult cardiovascular disease risk. So look, it's probably there. And in terms of what, but you know, to exactly what level and what are the risk factors for being more likely to have disease, we don't really know yet. From our own P4 cohort that Greg mentioned, so the sort of following up after both normotensive pregnancy and preeclamptic pregnancy the first 5 years, we've actually got relatively reassuring child data so far. So at 6 months, the infant growth, there's a bit of sort of catch-up growth trajectory with the preeclamptic babies, which isn't necessarily a healthy thing in terms of your long-term health. At 2 years, so one of my honours students looked at this last year with our academic dietitian and paediatrician, Maria Craig, and we're just preparing it for publication, so it's not been peer reviewed yet, but at 2 years, you know, the physical health was pretty similar of the preeclamptic babies and the normotensive pregnancy babies, which was reassuring, and the developmental health was also similar. So in a sort of fairly close to overall, you know, most preeclampsia and hypertensive diseases occur close to full term, and that's certainly what our population is at St George and what the P4 population is. So in that population, it doesn't seem to be, you know, so terrible. In terms of what can you do about it, look, healthy mother, healthy family, healthy child, right? So, you know, if mum is taking care of her own health by, you know, exercising regularly and trying to put healthy food on the table, then that will, you know, that will help the child health and decrease any long-term risks for the child as well. So,
the other thing is that, you know, a lot of these women that are hypertensive, you're treating them with multiple antihypertensive agents, which most of us that look after hypertensive pregnancy, you know, you worry about, you know, is this going to affect the baby at all? And as Amanda says, there doesn't seem to be any major difference in terms of the women who've had preeclampsia and those that haven't. So I think that's reassuring for clinicians when you're giving them all these drugs, you know.
Can I ask a question?
No,
it's
no.
to Greg and Amanda. So Greg, your money slide, you know, the one that showed that in fact if you develop preeclampsia, then this is the risk of all of these other things. What is the theme that runs across all of them? I mean, why is it that they have this increased risk of all of these things?
Well, I think I mean, there is a lot of debate in the literature that Amanda was alluding to. You know, do they have an underlying predisposition? And, you know, some of the data that I showed in terms of the metabolic syndrome showed that they do have, and there are certainly a lot of work in the literature that shows women who've had preeclampsia are more likely to develop the metabolic syndrome, and that is probably underlying a lot of them. But there's also this lot of research which shows that it is related to abnormal placentation and changes into the vasculature of women by the very process itself. So I think, you know, like everything in medicine, it's probably a mixture. And, you know, this group that we're identifying, the 20% that I was talking about, are going to be more overweight. They're going to have abnormal lipids. They're more likely to have impaired glucose tolerance. So in some ways you will have selected them out already, but you know, previously people wouldn't really have looked at them. They wouldn't have gone back to their GP because their GP would have thought, oh, you know, you're a 30-year-old woman, you're not likely to have any problems, you might be a little bit overweight, your blood pressure's, you know, 130 on 80, you know, that's pretty normal, and so they wouldn't have done anything.
Just because, I mean, all of these conditions are also associated with dysbiosis.
Yeah.
Hypertension, obesity, metabolic syndrome, you know, fatty liver, all these things. And fatty liver is no very strong, you know, risk factor for heart disease. So, you know, they're all kind of interlinked somehow, which is quite fascinating.
Yeah, and all inflammatory conditions as well.
Yeah.
So, on.
That slide that you showed where the survival curves over years.
The Mormons, you mean? Yeah. Yeah.
Yeah. Why do you think the gestational hypertensives?
For exactly that reason. For exactly that reason. Yeah, I think the gestational hypertensives do tend to be bigger, so they do have more of the metabolic syndrome than comparing them to the preeclamptic group. We did look at gestational hypertensives as well, but we just didn't recruit nearly as many of the gestational hypertensives
But
as
yeah,
the preeclamptic.
my students have been working on the metabolic side of P4, have found that even the quite small gestational hypertensive group are substantially metabolically worse. So their insulin resistance levels are higher, their lipids are worse at the 6 months, 2 years, 5 years, and they're also much more overweight. So I think, and part of the shift as maternity care providers and then out into the community that we have to make is because if you just have gestational hypertension, not the sort of multi-system disorder of preeclampsia, perinatal outcomes are overall really very good. We've kind of gone, oh yeah, well fine, and then the blood pressure goes back to normal and it goes away. But actually that group of women are often the women who, yeah, they've come in older, more overweight, less fit, with more tendency to metabolic syndrome, and then they don't quite get some of them get preeclampsia, but some of them just, in inverted commas, get high blood pressure, and then they continue unabated on their awful health trajectory, basically. Yeah.
But I mean, I think EMAD's magic pill, that the sort of magic crapsule, that would be ideal for, you know, that group, you know, that you could, you know, if you had women who are planning pregnancy and, you know, they were overweight and things, you could give them the magic
Well,
crapsule.
if only if it was simple as a magic pill.
Yeah.
So, Ina, talk to us more about...
I mean, I think there's a question from the audience.
Yeah.
Just the aspirin, Amanda, you mentioned the aspirin.
Yeah.
What's the success rate with aspirin?
Well, so in early onset, it's only an early onset preeclampsia, but it reduces it by over 50%. The risk.
This is fascinating because if you look at, I'm a gastroenterologist, so bowel cancer, you know, kind of prevention and chemo prevention, and aspirin is only 50% effective.
Yeah.
And we published a paper 2 or 3 years ago about aspirin, trying to figure out why, you know, why is it only 50% effective? And it turns out that in fact, this is in animal models, so it's not human data, but one, aspirin actually gives you a favorable microbiome. But the other thing, if you've got an unfavorable microbiome, there are certain bugs that can metabolize it and make it less biologically active. Yeah. So basically, you take it and it's useless because it's already been destroyed. So I think it's all this 50% business.
Well, yeah, and I mean, that's 50% in one randomised trial. Like the overall aspirin data is not quite as good as that. But interestingly, in the Asprey trial, one group, and you could argue that it was actually unethical to randomise them in the first place because they were clearly already high risk because they had chronic hypertension. But a subgroup that didn't seem to benefit really much from aspirin was the chronic hypertensives group, who potentially already had that unfavourable aspirin metabolising biome. Who knows?
So 1 in 25 Australian babies are born from IVF these days. The embryologists would like to say it's a sterile environment and you grow this embryo, but it's probably not true. Do you think, is there a microbiome relationship to the think there's any correlation there? I mean, these embryos are grown in media with gentamicin.
Sure. Yeah. No, I mean, I think they're probably the most sterile of all of the, the babies that are produced, as opposed to the natural way, because everything is controlled precisely as a laboratory. I mean, I've seen the process, and set up. I think it was really quite nice. We went there. So essentially, I think that's a very controlled, probably sterile situation. But naturally, I think it would be completely different. We had a study whereby we wanted to check all of the, like all the different. I'm going to use the wrong terms now because I'm not a obstetrician or a gynecologist. But, the sheath and then the actual swab and everything else. Like where do you get the contamination? Because as you go in, there's a number of potential contaminants, and I think that's a study that we haven't really finished yet. But there was definitely a signature from some of the external to where the implantation takes place. So you're introducing something as you go in, which makes sense because it's not sterile.
Yeah. And I mean, you're right. I mean, IVF pregnancies are more at risk of getting preeclampsia. But, how much of that is related to the fact, I know on those studies they try and control for age and all those things, but how much is due to things like they are older women, they may be more likely to have, metabolic syndrome and things like that. So, that, I mean, it's always hard to know, isn't it? Yeah.
We've got another student coming on next year who will be specifically looking at IVF pregnancies and microbiome. So seeing whether or not there is a difference with all our preconception data.
I'm just wondering, what are we doing to the mums and bubs microbiome? All these Ben Pen we do for GBS.
all these.
Ben Pen for GBS.
Oh, Ben Pen, yeah.
Yeah.
Yeah, although having said that, it's a single event and a single dose of antibiotic. Well, sometimes it's 2 doses, or maybe even 3 if it's a long labour. But like when you consider the entirety of the complexity of everything, it is still drawing a bit of a long bow to say that that's going to have like lifelong bad impacts. I mean, you were talking about antibiotics in general, the public talk. Maybe if you,
But if they're having sex, they should have had a Caesar already.
Yeah, we're talking about antibiotics. I mean, I think if one course of antibiotics is not, you're not kind of losing all hope, because you will recover, especially if you've had a resilient microbiome that is able to reseed and we've just finished a study looking at Helicobacter pylori eradication. So you're giving a quadruple therapy, all of it having an antibacterial effect, and then following them up for 2 weeks, 8 weeks, a year, 2 years, 3 years, and 4 years. And we showed that obviously after 2 weeks of treatment, your microbiome is completely decimated, but by 8 weeks, you've recovered the diversity of the microbiome and the composition, which is very reassuring, because I think there's a lot of, my big interest is, prevention of stomach cancer, Helicobacter and stomach cancer. So there's a reluctance to dish out eradication therapy on a global scale to prevent gastric
that
cancer.
would be a gut feeling, Emma.
So it's reassuring to know that if you take a course of antibiotics, it's not the end of the world. But if you take lots of courses of antibiotics at regular, like during childhood in particular, that would actually increase the risk of developing problems in the future. So if you take it between the years of 1 and 3, and if you take antibiotics, PPIs, or H2 receptor antagonists, 1, 2, or 3 of these drugs, your risk of developing future diabetes increases. And there's more recent work about, not in children but in adults, the risk of colon cancer goes up as well with antibiotics. But it would tend to be, I think there's a dose effect. I think the more you keep hammering your microbiome and causing the dysbiosis, the greater the risk.
Do you think we do consent well then when we prescribe PPIs, antibiotics?
So, look, I am leading this campaign against the PPIs, not because I don't think they're wonderful drugs and because they have indications. It's just because there are so many people that don't need them. I mean, if I do a ward round tomorrow morning and I go around 30, 40 patients, 80% of them will be on a PPI, and only 10 or 15% actually need them. And that's the problem. And on a global scale, that's going to cause problems. But I think in terms of counseling the patients, if you're starting it, I would always tell them, this is for a finite period. I'm just treating your esophagitis. After this, we're going to have to try and de-prescribe, and then we have to go through it, gradually and all that kind of stuff. But it's just so easy to just dish it out. And of course, it's available over the counter, so you can't control this. Antibiotics, I think, is different because we use them for a reason. I think it's yeah. Hopefully, yeah.
There's always a reason. Sometimes it's not a very good one.
Yeah.
Sometimes not a very good
How
one.
can I get this person out of my door because we're
Yeah, true.
This might be a really silly question, but how do you determine someone's got a good microbiome?
Yep.
Is it like good bacteria versus bad bacteria?
That's a fascinating. It's a very important question. That is actually the most important question in the microbiome field, and the one that doesn't have a clear answer, because the definition of normal up till now has been based on taxonomy. So basically, you're describing, there are some good bugs and some bad bugs, and then you've got a ratio of this to that and that kind of stuff. Diversity is a very important parameter. So if it's more diverse in the gut, it usually correlates with a healthy microbiome. But in answer to your question specifically, we have another big study at the MRC called the Healthy Optimal Australian Microbiome, the HOME study. Play on words, because we want to create home, to which we bring all of these people back, preeclampsia, hypertension, risk of cancer, whatever it is. And to do that, I think we've started from the end, not from the gut and looking at the bugs, but from the phenotype. So who are the healthiest people in society? We asked that question, and then we looked at the microbiome. So we're recruiting athletes. I was asked a question once to say, if you were to get an FMT, who would be your donor? That's how the whole thing started. And I thought for a while, Olympic athlete. I mean, I love to have this kind of metabolic superiority and cardiovascular perfection, And then we thought, hang on a minute. So, athletes obviously are metabolically, physiologically perfect. They're lean, they look after their diet and everything else. So we're looking at that particular group. But the other one that is just absolutely fascinating are the ones that have been tested by time. So you could have an athlete who's in top, peak condition now at the age of 30, they drop dead at 35. It can happen because they can still be tested by time. Whereas if you look at the ones that have reached 100 and have still retained their marbles and they don't have dementia, respect. I mean, you'd want to know what their microbiome looks like. So this is the study, actually. Say that again? The Queen. Yeah. Well, she's under a lot of stress, I think. The Queen. Yes. She's. Right. Oh, Prince Harry. That's right. So I think that study in the MRC, the HOME study, is going to provide the template for Australia, because I think we're trying to get it as diverse as possible. But looking from the phenotype and then seeing what the taxonomy looks like, what the metabolomics look like, what the transcriptome, we're doing a multi-omic assessment. So hopefully that will give us a much more robust signature, for health. And this is different from I didn't have time to talk about the testing. And a lot of your patients will have sent their sample to Queensland to get tested for, or Melbourne or whatever it is, to get a microbiome report. And they get 50 pages of completely unintelligible jargon, and then bring it to me to try and explain it. So I think their normal is everybody else that filled out a questionnaire and said, I don't have this and I don't have that. You see, that's not really that robust, to be quite honest. Yeah.
Anyone else? Madeline, would you want to say anything? Yep. Come on.
Thank you. I'm Madeline Tynan from the Tynan Motor Group and the Michael Tynan Challenge. We were actually the ones that brought this study up here for you for Orange. Our family company has been going over 56 years. So it seems quite strange that we sell cars, but we're also helping out with the medical research. But we actually feel very strongly. My dad started it, as I said, 57 years ago, and he always believed in giving back. So we really believe in actually giving something back. I now have a daughter that lives in Orange, and we have some very close friends that live in Orange. So we really thought this was a great place to start. and we'd like to really appreciate the people that are online and for everyone coming today. But we'd really love you to spread the word and actually give the researchers back some people that would really love to be on the study. Without the study, we won't be able to take this further forward. I'd like to say appreciation to the doctors for giving up their time and coming up here. Obviously, you're all extremely busy, and for them to come up here and to give up their time to explain the study. Obviously, there's a lot that we sponsor, and the Microbiome Centre is extraordinarily wide and diverse, and we'd love to bring some more information back to you at a later state. Please spread the word about the studies that you've seen tonight. If you'd like anything further, obviously all the information is there. Our team at Tyne & Motors have put together a flip book that has all the information of every doctor and professor that has been here tonight. And really thank you for coming out on a cold winter's night. I appreciate it very much. Thank you.
And I'd just like to thank Madeline for really instigating this. I mean, Madeline's been involved in supporting medical research for over a decade, and it was really it was her initial idea, and I don't know when we were talking about it, but it kind of just grew, and her having Prue here, living here, kind of ended up. And my major claim to fame was delivering all of Madeline's grandchildren and being her virtual gynaecologist as well. So thank you all for coming. Oh, sorry, Miguel.
You forgot the raffle of the Mercedes.
That's
We're actually technically out of our PMAs. We're not under our fundraising channel, which is my Climate Challenge. Don't tell the local Mercedes company.
Yeah, so Madeline very kindly lent us a Mercedes to drive up in here, which was fairly supersonic, and we still didn't know how to turn off the sat nav at the end, but thank you everybody.